sessions. So the first session is on IPC, infection prevention and control practices, and the second session will be taken by Dr. Larry Karsandi, who is also a microbiologist here. So he will be talking about biomedical waste management in district or in the hospitals of Meghalaya. So straight away, I will talk about infection prevention and control practices. So we all know what infections are, right? So just wait a second, my slides are not moving.
Oh yeah, the side.
Yes. Okay. So first of all, why do we care about infection prevention and control practices? So the first thing that comes to our mind is actually, it's a safety of the healthcare workers. That is all of us who are working in the hospitals and laboratories across the state. So the first thing that comes to our mind on why IPC is important, infection prevention and control practice is important, is the safety of healthcare workers. Secondly, we must not forget our patients. So the second most important thing of why IPC is important is for the safety of patients. So these days we talk a lot about patient safety, and we have heard about the word patient safety. So IPC is one of the things that ensure that the patient is safe whenever he is admitted or he comes to the hospital for any kind of treatment. The third one is if you talk about quality. So now we are on the way on the road to NCOAS certification and all, and so many other quality initiatives of the government of India, like KAICAL, like NCOAS, like NABL, NABH. So IPC is actually a big area of concern. Okay. So if you look at any criteria, you will see that IPC is a big area of concern where, if we don't do well in IPC, and we lose a lot of points with regards to quality initiatives. And the fourth thing is that by following and by knowing and by practicing infection prevention and control practices, we are also preventing and contain the antimicrobial resistance. So this is a huge problem actually in the present world that we are living. So we are treating patients with antibiotics, all kinds of infections we treat with antibiotics, but then these microorganisms, they are able to evolve and protect themselves against these antibiotic drugs that we're using. So, and then not only that, the production or the research or the, manufacturing of new antibiotics is very slow, and we don't have new antibiotics in the market as of now. So it is very imperative for all of us who are working in the health setup that we follow IPC practices to the dot, so that we actually help in preventing and containing the antimicrobial resistance spread and transmission in the community. So these are the four reasons why IPC is important for all of us who are working in the government health setups in the state of Meghalaya. So in order to to implement all these things in place, we need a committee, right? So every hospital, whether it's in the center, it's a PHC, hospitals, and so on, needs to have an infection control committee. And this committee, if I might say, should be one of the strictest committee that should ensure that all the members in the committee should always attend the meetings at regular intervals. So it is because in my experience, I've seen that whenever we have a meeting for infection control, only a few members will attend this the particular meeting. Only the chairperson and the secretary and a few other members attend. But then most of the members, they don't even attend the meeting. So I urge, especially for people for like sir and all who are in the administrative position, that you make this committee very strict. So every member will attend the committee meetings at frequent intervals. So this is the structure of the infection control committee. So please let me know if there's any problem with the slides or anything. Please let me know so that I can take action immediately. So this is the structure of the infection control committee. So the chairperson usually is the head of the facility. So it will be a medical superintendent or the MO in charge. And the member secretary usually should be a microbiologist, but in many hospitals, we don't have microbiologists in every hospital. Even in district hospitals, we don't have microbiologists. So any doctor, any medical officer who is trained in infection control and prevention practices can be a member secretary here. So the main job here is of the secretary. He will be doing all the works which relates to IPC. And other members that are in this committee are: number one, the infection control nurse. This is a very important member of the committee. So the recommendation is that there should be a minimum of one infection control nurse for 250 beds. So in case of a bigger hospital where the number of beds is more than 250, then you will need maybe two or three nurses. But most of our hospitals, I think less than 250. So we can have one infection control nurse who's very well versed with infection prevention and control practices, so that to implement and monitor all the practices with regards to IPC. Then you need representative from management, from administration, from the nursing services, medical services. Then a representative of relevant medical and surgical disciplines, like from the medicine department, surgery department, orthopedics department, like that, and so on. Then biomedical waste management in charge is very important to be in this committee, and representation from the support services as well, like from the OT, and so from the CSSD or TSSU if you have in your facility, from the housekeeping, sanitation, department, laundry, engineering, and from pharmacy and stores and materials department. So all these members must be present at all meetings of the infection control committee. So what are the things that are expected from this committee? So the first and foremost thing is to develop SOPs, right? So the first thing is to develop an IPC
Mà đó
policy or
mà
IPC.
tao đó dẫn á lịch thuốc
Okay,
dẫn á.
can you mute yourself?
Vậy nó mạnh đi á.
Excuse me. So the first and foremost thing of the committee is to develop SOPs on infection prevention and control practices, on biomedical waste management practices, on laboratory safety, and etc. So there are these SOPs that needs to be developed by infection control committee. Then after the SOPs are developed, then whatever is written in SOP needs to be implemented in the hospital. So implementation of the IPC, which is again the most important function of the HICC. And after implementation, after a few weeks or a few months, you can start doing the monitoring and auditing of all the whatever is being implemented. Are people following or not? Whatever is whatever is taught to them, trained to them, told to them. So we have to monitor and audit. So there are certain methods and materials to monitor and audit the IPC practices, which I will be sharing later. Then the fourth important thing that the ICC can do is the surveillance. Okay, so number one is HAI surveillance. So HAI means healthcare associated infections or hospital acquired infections. So nowadays we call it healthcare associated infections instead of the hospital acquired infections. And the second surveillance is on AMR surveillance. So that is the antimicrobial resistance surveillance. So hospitals with microbiologists will actually know very well what is AMR surveillance. Then the fifth thing that the ICC should do is conduct regular trainings to the staff of the hospital. So trainings has to be regular basis. And for new staff who has just joined the hospital, so induction training should be given to them whenever the new staff have joined the hospital. And last but not least, when all these five things are being accomplished by the ICC, then we can have something which is called as antimicrobial stewardship, which is a more comprehensive, comprehensive word for all these practices that we are talking about. And then what is another thing that is expected from the ICC is that you have a meeting uh, at least once a month. So it should be mandatory that once a month a meeting is being conducted with regards to infection control and practices. So at least once a month. So in case you need to sit for more meetings, for example, when there's an outbreak of HAI, then you can have more meetings in that particular month. But at least once a month, there should always be a meeting to discuss matters related to IPC. So so I've talked about the infection control committee. Now let's talk about the heart of the matter. That is what are these practices? What are the things that we need to know about IPC? So infection prevention and control practices. So these are the four things that we need to remember, we need to know when we talk about IPC. So, number one here is are the standard precautions. Number two are the transmission-based precautions. Number three are the HAI, healthcare associated infections. And the fourth one is the environmental microbiological surveillance. So, I will be talking about all of these four one by one. So, the first thing is that we talk about our standard precautions. So, as the name suggests, standard precaution, that means it's something basic. So these are the precautions that are basic that we need to follow, when we take care of a patient, or we take care of for laboratories, when we process samples. So we follow all these precautions irrespective of the infection status of the patient. So we do not actually care whether the patient is HIV reactive, hepatitis B, hepatitis C reactive. We don't actually care whether. So we follow all these precautions for all kinds of patients and for all kinds of sample. So it's a universal kind of thing we follow for everyone. So these are the primary strategy actually for minimizing the risk of transmission of the microorganisms in the healthcare facilities. So we will. So these standard precautions are, it's a big terminology actually. We have seven components of standard precautions. So if you see in different quality initiative like KaiCup and all, there is a checklist that says that whether the staff know about the standard precautions or not. So these are the seven components of standard precautions. So you might as well guess. The first one is hand hygiene. So hand hygiene is actually kept at number one. I think this is strategically kept at number one because hand hygiene actually is the most important aspect of infection prevention and control practices. So we have learned that during the COVID pandemic that hand hygiene is actually the most important step to minimize the risk of infections. Then the second component of IPC is the proper the proper usage and of personal protective equipment. So whether how do we use the PPE? How do we when to use and when not to use of PPE? This is very very important. And the third component of standard precaution is the respiratory hygiene and cough etiquette. So this again we have learned during the COVID-19 pandemic, where when we sneeze and cough, what are we supposed to do and what we're supposed to teach our patients that come to our hospital on this respiratory hygiene and cough etiquette. Then the fourth component is injuries from shock. So we need to actually practice certain things that will help us, that will prevent us from getting injuries from sharp instrument. And whenever we use sharp instrument, what are the things that we need to do to prevent ourselves from getting sharp injuries? And not only that, accidents do happen, but whenever accidents happen like this, so we need to know the proper protocol on what to do in case these accidents of sharp injuries or splashes with blood and body fluid, it happened to any of our staff in our hospital. So we need to know. Then the fifth component is environmental cleaning. So environmental cleaning is very important. How do we clean the floors? How do we disinfect work areas? How do we disinfect patient reusable items and all? So it's very important. Then the sixth one is disinfection of patient care items. So there are so many items in the hospital that we are reusing for several patients, like scopes and everything, like linens and all. So we need to know how to do, the proper way to disinfect patient care items. And the seven, last but not least, biomedical waste management. So this is also a very important aspect of IPC. So if we don't manage the biomedical waste generated in the hospital, we end up transmitting infection to our staff, to our patients, and moreover, we are contributing as well as to pollution. So this will be taken by Dr. Larry, the seventh component of standard precautions. So let's move ahead. I will talk about each of these components of standard precautions. So the first one is hand hygiene. So according to the World Health Organization, hand hygiene is the single most important measure for prevention of infection because our hands actually are the most common vehicle, okay, for the transmission of healthcare associated pathogens. And studies have been conducted, all over the world that if we increase our adherence to proper washing our hands, like how we follow the steps and the moments of hand hygiene in the hospital, we also contribute to decrease in HAI, that is the healthcare associated infections. So when we talk about hand decontamination, we have two types. Okay, so the first one is routine hand hygiene. and the second one is surgical hand scrub. So surgical hand scrub is for personnel who are working in the operation theater, for surgeons, for surgical nurses, and for all who are working in the operation theater for while performing any kind of surgical uh, method. So this has a different uh, steps and procedures and timing as well. So, but for most of the staff in the hospital, we are following only the routine hand hygiene. So, under routine hand hygiene, we have two types of routine hand hygiene. That is, the number one is hand washing with soap and water, and the second one is hand rubbing with an alcohol-based preparation. So, hand sanitizers and soap and water. So, hand washing with soap and water is actually preferred, when hands are visibly dirty or soiled. Whenever our hands are dirty or soiled with blood or body fluids, then we wash our hands with soap and water or after using the toilet. And the third indication of hand washing with soap and water is after removal of our PPE, personal protective equipment. That is actually the PPE that's supposed to be, taken off at last is the mask. Let me just mute people. Tura MCH, can you mute? Requesting all the participants to mute their mic so that it doesn't disturb. Okay, so then the second type of routine hand hygiene is the hand rubbing with an alcohol-based preparation. This is a preferred method for routine hand hygiene if hands are not visibly soiled. So in most situations in our hospital, so hand rubbing actually is the go-to, routine hand hygiene method because it is easily accessible and it has uh, several advantages over the soap and water. So as you can see here, the alcohol-based hand rubbing is easily accessible at point of care. It has excellent antimicrobial activity against all the gram-positive and gram-negative vegetative bacteria, M. tuberculosis also to some extent, and a wide range of fungi, and also generally good antimicrobial activity against envelope viruses. So the most of the viruses that we encounter in the hospital are usually envelope viruses. Whether you talk about HIV, about hepatitis B, hepatitis C, rabies, they are all envelope viruses. So that's why alcohol-based hand sanitizer they work really well against this kind of viruses. What the hand sanitizer doesn't work is against non-envelope viruses like viruses that spread through the fecal-oral route like poliovirus, rotavirus, and hepatitis A and E. So for these kind of viruses, maybe the alcohol-based hand sanitizer will not work. And also for spores of bacteria. So so in order to do hand washing or hand rubbing, we have the six step. According to the World Health Organization, it is six step. There is a confusion actually among our health workers that before it used to be seven steps, now it's six steps. They really are confused. So now we are telling everyone that we follow the World Health Organization, which tell us that there are six steps of hand washing. Okay, so if you so there's a video here. Kindly all of you watch. So the patient wets his hand and he takes a soap. The first step is palm to palm. Then second step is palm to the back of the hand, both sides, and then the fingers interlace again both sides. Then the knuckles, both sides. Then the thumb. Then lastly the tip of fingers. Then he rinses his hands and dry his hand with a paper towel. Okay, so if you have seen in the video, what is being omitted from the other uh, hand wash step is the wrist. Okay, here the person did not wash his wrist. Okay, so that is the seventh step actually. So we're not following that anymore. We are following the six steps. So let's all follow that. And these materials that tell about the steps of hand washing should be actually pasted in every nook and corner of the hospital, especially in hand washing areas and hand rubbing areas where you keep your sanitizers and wash basins. So there's a difference between hand washing and hand rubbing. So if you see here in the hand washing, the entire procedure takes about 40 to 60 seconds. Okay, so that is the main difference between hand washing and hand rubbing. Whereas for hand rubbing, it's only 20 to 30 seconds because it takes that amount of time for the alcohol actually to dry out from our hands. So basically, the steps are the same, 6 steps. The only difference is that of the timing, because for hands it takes around 40 to 60 seconds, and for hand rubbing it's half of that, that is 20 to 30 seconds. So all these materials actually can be found online also in the WHO portal. They can be downloaded and be pasted in our hand washing sinks, and wherever the hand sanitizers are being placed in the hospital. And then these are the 5 moments of hand hygiene that are you know uh, mandated by the World Health Organization. So number one is before touching a patient. Number two, before clean aseptic procedure. Number three, after body fluid exposure risk. Number four, after touching a patient. And number five, after touching patient's surroundings. So these are the when we should do our hand hygiene. So these are the 5 main moments that we must do hand hygiene when we work in the hospital. So let's come to the second component of standard precautions. We have done with the hand hygiene. Now we talk about personal protective equipment. So this is not, I will not go into details of each and every PPE. So we all know these are actually the physical barriers that are used alone or in combination that will protect our mucous membrane, airway, and skin and clothing from contact with infectious agents. So we know the examples of PPE: gloves, apron, gowns, facial protection, footwear, and hair cover or cap. So let me talk a little bit about gloves. Okay, so because most of the time in a hospital we see that uh, whenever we wear gloves we feel safe, and we do not care to do hand hygiene anymore, and we don't change the glove. So actually the recommendation is that we use single gloves for a single patient. We should not reuse gloves for for more than one patient. So a single pair of gloves should be used only for one patient. Okay, so that it minimizes the spread of infection to another patient. So these gloves actually should be worn as additional measure, but not a substitute for the hand washing. Because most of us, we when we wear gloves, and we use that same gloves for so many patients, and we forget to actually do hand hygiene, hand rubbing, or hand washing. So in our hospital setup, we are using 3 types of gloves. Number one are the clean, non-sterile gloves. Number two are the sterile, single-use gloves. And number three are the heavy-duty and heavy utility gloves. So heavy-duty gloves is being used by our sanitary personnel who collects waste and everything. So these are thicker gloves, that protects them from getting injuries from shocks and all. Then the sterile gloves, as the name suggests, are supposed to be used only for sterile purposes. For example, for operation theaters, for inserting a catheter, for collection of blood sample for a blood culture. But then in most situations, we should use clean, non-sterile gloves. So for collecting blood in the laboratory for laboratory tests, we need to use these clean, non-sterile gloves. They are quite cheaper when you compare with the sterile gloves, which are more expensive. So we know quite well when to use gloves, okay? But then the problem is that we do not actually remember that when our gloves are not supposed to be used. So this is a slide on that tells us when gloves are not indicated. Okay, so we're not supposed to use gloves when we take blood pressure, temperature, and pulse, performing subcutaneous IM injections, bathing and dressing the patient, transporting the patient, caring for eyes and ears without secretions, any vascular manipulation in absence of blood leakage. So we're not supposed to use gloves in these kind of situations. And while using the telephone, we don't use gloves. Writing in the patient chart, writing in registers as well, giving oral medications, distributing or collecting, patient dietary trays, removing and replacing linen from patient bed, placing non-invasive ventilation equipment and oxygen cannula, and also moving patient furniture. So, but then most of the time we see that our health workers are using gloves even in this kind of situations. Okay, the writing on the register with the gloves hand. They're typing on the computer in the laboratory. We see that a lot. Okay, we're typing on the computer using gloves hand again. So it's the gloves that have been used for patient care, for the testing of the patient samples, should not be worn while doing all this other things. So these are uh, when gloves are not indicated. So I will not talk about this thing because for sterile gloves we are supposed to use only for sterile procedures, and clean gloves for for other procedure, like for example get, IV insertion and removal, drawing blood. Okay, discontinuation of venous line, pelvic vaginal examination, suctioning non-closed system of endotracheal tubes. All this. Okay, then the second component uh, of of PPE are aprons and gown. I would like to highlight this because I have seen that doctors and our nurses and even our lab technicians, they used to wear apron even outside of the hospital, outside of the laboratory. So they go into a restaurant, they go into a cafe near the hospital, canteen. They are putting on their apron. So actually that is a very bad practice because we have come in contact with patients, with patient samples, and it is not right for us to just go outside of the hospital with with aprons and gowns that we have worn in the hospital. So it's my humble request that we discourage this practice of wearing apron and gowns outside of the hospital or outside of the laboratory. Okay, so I'll move on to the next component of standard precaution, that is the respiratory hygiene and cough etiquette. So it is whenever we have a cold, where we cough or sneeze, we should turn away our head from others and use a tissue to cover your nose and mouth. Please mute yourself. Please mute yourself. Okay, then if we have used a tissue, then we need to drop the tissue into the waste bin. And the third one is that if we do not have a tissue, then we use our sleeve. Then don't forget to wash our hands after we have used the tissue or something for coughing and sneezing. So this is what we should pace actually again in the hospital, so that we are able to educate our patient and patient parties on how to do respiratory hygiene and cough etiquette whenever they are in hospital. So this help in preventing the spread of any respiratory infection in the hospital. Then the fourth component is the prevention of injuries from shock. So we need to actually take care while we are handling shocks. So if we're using some needles and all for stitching and all, we should not bend, we should not manipulate the needle actually. Should not be bent, should not be broken after use. And then any then whenever we use scalpel or anything that is sharp, we should position the sharp edges away from ourselves. And while using needle and syringe, for example, for injection, for drawing blood, then we should not recap the needle anymore. But in case it is necessary, then we use a single hand scoop method, where we just use a uh, single hand to to recap the needles. And then another thing important about preventing injuries from sharp is that we dispose them properly. So whenever sharps are being used, we dispose them into the puncture-proof container, the white container that we used to see in our hospital. And then these should be pre-treated with hypochlorite solution, disinfected or pre-treated, and should be disposed of in the sharp pit, safely. So, but then sometimes, in spite of all preventive strategies, in spite of preventive methods, we still end up with, sharp injuries or splashes with blood and body fluid into our eyes, into our mouth, okay, into our skin. So, in those situations, what are we supposed to do? So, these are the posters that we have made here in Pasteur Institute. So, you can also have these kind of posters in your hospital, so that everyone will know what to do in case of this kind of accident. So if there's any needle stick injury, that is needle prick. So for all kind of accident, the first thing that we must do is that we should not panic, because once we are panicked, then we end up doing a lot of things that we are not supposed to do. But then it's easy said than done, because whenever it happens, and especially if the patient is actually reactive for those bloodborne viruses, then we are very scared. Okay, so it is easy said than done. But then let's remember that whenever this kind of accident happen, we try to keep ourselves calm, that we don't panic. So the second thing to do in case of a little stick injury is that we wash wound with soap and running water. So we don't do anything else from that. We do not scrub the affected area. We do not squeeze the affected area. Although we encourage the wound to bleed, but then we do not squeeze the little prick area. And another thing to remember is that we do not apply antiseptic. In the beginning, I was mentioning when I was talking about the hand rubbing that alcohol works pretty well against HIV. But then in this situation, we do not use antiseptic because the HIV usually attacks the lymphocyte, that is the white blood cells. Okay, so in addition to little prick into our hand or fingers, we are putting betadine, or we're putting alcohol, so it causes more inflammation. And so in that process, the HIV gets more chance to attack the white blood cells or the lymphocytes that we are talking about. Then if we have exposure to blood to the eyes, using blood or body fluids, then we wash our eyes with lukewarm water, normal saline. We can sit on a chair, tilt the head back, and ask a colleague to gently pour water or normal saline over the eye. And if you're wearing contact lenses, then we leave it in place and irrigate the eye, then remove the contact lenses later on. And the most important thing, after this first 8 steps has been done, is that we report immediately to the nodal officer or the doctor in charge for post-exposure prophylaxis. Okay, so out here, I've written here in our poster, we have written report immediately to doctor in charge or nodal officer. So what we have done here, that we have also kept the name of the doctor and as well as the phone number, because our staff, whenever they have accident, they can just call the doctor, the using the telephone number or the mobile number. So there should be a doctor who is very well trained in post-exposure prophylaxis, who because his job eventually will be to do the risk assessment. See, I'll show you this flow chart. So there'll be a risk assessment by the doctor in charge. Okay, then documentation, recording, then you send to the ICTC for counseling, and then a decision has to be made. Okay, whether the post exposure prophylaxis drug is needed or not for HIV. Okay. Then I would like to stress here that reporting has to be immediately. Okay, so we do not wait for 1 day or 2 days to report about the accident, about the needle stick, or about the splashes of blood. We report it immediately, because if we are supposed to take the drugs, okay, for HIV, that that kills the HIV virus, we are supposed to take the drug ideally within 2 hours, and preferably 72 hours. But after 72 hours, it is actually not advisable or not recommended, and it doesn't work if we take the HIV drugs after 72 hours. That's why it is imperative for all the staff, whenever we have accident, this kind of accident, we need to report immediately to the doctor in charge or the nodal officer for post-exposure prophylaxis. And in case of hepatitis B, for example, the patient is hepatitis B positive, then we make sure that our staff are vaccinated against hepatitis B. All our staff, all our personnel in the hospital must be vaccinated 3 doses of hepatitis B vaccine. And if any one of our staff are not fully vaccinated, then we must take their names, we must take their data, that that they need to complete the hepatitis B vaccine course of 3 doses. So because if we have taken all the 3 doses, then even if the patient is hepatitis B positive and accident happen, then there's no other thing to be done, because you are protected. But in case the person or the personnel is not completely vaccinated or non-vaccinated, then immunoglobulin against hepatitis B has to be given, which actually is very expensive and very hard to get also. So out here in Shillong also, we are having problem in getting the immunoglobulin. Mm. So there was uh, there's one student actually who came to me, but he has to go all the way to Guwahati to buy the immunoglobulin, which is again very expensive. So staff immunization is very important. So hepatitis B, all the three doses, as well as tetanus toxoid. Records of vaccination or immunization should be maintained for all the staff, and also a periodic health checkup needs to be done for all the personnel working in hospitals. So an annual health checkup is very, very important, and record should be kept. Then the sixth component is this is the fifth component is this environmental cleaning and disinfection. So work areas, in the laboratory, in the nursing station, they should be clean, okay, with freshly prepared, should disinfected with freshly prepared hypochlorite solution, 1% before and after use. And laboratory equipment should be decontaminated with appropriate disinfectant on a routine basis. Appropriate, so the word is appropriate. In case of any work surface which is metallic, we cannot use hypochlorite solution. So in that case, we use alcohol based, decontamination, decontaminant to decontaminate the work surfaces. Then then for cleaning of the floors, we are all following the three bucket mopping system. So this is all of us we know about this. So the first bucket, which is blue in color, contains water with detergent. Then the second bucket contains only water, and the third bucket contains water plus disinfectant. So detergent first, then only water for rinsing. Then the last one is the disinfectant. So housekeeping staff needs to take the mop and dip first in the first bucket that contains water and detergent, squeeze the excess water away, and then proceed from the cleaner to dirtier area. So for example, in a room, you should start from the corner in one direction, and lastly the door, okay, where it is very, very much more dirtier than the corners. Then the mop needs to be rinsed in the second bucket, which contains only water. Then again, squeeze out the excess water and dip into the third bucket, which contains the disinfectant. Again, squeeze out and then proceed with the same procedure, cleaning from the cleaner to the dirtier area of the room. So a checklist has to be there in every section of the hospital, whether this three-bucket mopping system is being done properly or not. Then something about spill management. So in every corner, in every part of the hospital, there should be a spill kit. So in the nursing station, there should be a spill kit. In the OPD, in the emergency, in the laboratory, there should be a spill kit. So these are the things that are there in the spill kit. Number one is the caution signage board. Okay, so we can make it out of cardboards and all, or we can buy it from the market, the fancy ones. Then we need to have PPE, all this gloves and gowns and masks and goggles and shoe cover. Then we need to have some absorbent material like tissue, newspaper, gauze, cotton, or some waste paper. Then we need to have a freshly prepared hypochlorite solution, and lastly the yellow biomedical waste color-coded bag. So whenever there's a spill, why don't they mute themselves? Okay, so whenever there's a spill, we need to place the caution sign near the spill area and put on appropriate PPE. So the word here is appropriate because for a small spill, we don't need to put on the full PPE. We need to put on the appropriate PPE. Then you place the absorbent paper over the spillage area to allow excess of blood and debris to get absorbed. Then on top of that, you prepare the freshly prepared fresh 1% of sodium hypochlorite solution and pour it over the spillage area. So we need to leave it for some time. That is called the contact time. So in case of a small spill, we leave it for 10 to 15 minutes, and for a large spill, we need to leave it for 30 minutes. So small spill is anything less than 10 centimeters, and a large spill is something more than 10 centimeters. So after the contact time is done, then remove the paper with gloves hand and discard it in the yellow bag, and then mop the area and remove our PPE in following order. Remember that the mask should be the last PPE to be removed, always, not just for spill management, for all other situations as well. Then lastly, to perform the 6 steps of hand washing, like I've mentioned earlier. Then the next component will be the consumption of patient care items. So the patient care items, there are so many of them. So it is in one slide. So actually, the hospital in disinfection policy should be prepared, from the hospital on how to decontaminate or sterilize any patient care items that needs to be reused. Okay. So, but then the disposable equipment or patient care materials should not be reused. Only those that are not disposable can be reused. So we will share a PPT with all of you regarding the decontamination of patient care items. Actually, there's supposed to be a session taken by one of the doctors, but she's not. She has to go on some important work, so she's not able to take the session today. So we will share her PPT with all of you so that you get a glimpse of what to be done in case in case you need for the contamination of patient care items in hospital. So the last component is waste management. So this will be taken by Dr. Larry Kharsandi later on. So let's move on to the next part of the IPC, that is the transmission-based precaution. So we have already finished the standard precaution, which we are following for all kinds of patients. Okay, we don't know whether the hepatitis B, hepatitis C, HIV. We are following for all patients and for all patient samples. But transmission-based precautions are precautions that are uh, only for infection that we already know, how they are spread, how they are transmitted in from person to person or in the community. So based on the route of transmission, we have three types of transmission based precautions. Number one is the airborne precautions, number two is droplet precautions, and number three, contact precautions. So number one and number two, airborne and droplet, they are both spread through the air, but there are certain differences between airborne and droplet. And the third one is contact. So contact can be direct contact, or indirect contact. So I will talk about this one by one and what we're supposed to do in case this kind of patients come to our hospital. So when we talk about airborne precautions, they are actually very, very small particles. They are droplet nuclei of about 1 to 5 micrometers only. So they are very, very small. Because they are small and they are very light in weight. They get suspended in the air for varying period of times and also travel long distances, about more than 1 meter. So example of airborne uh, pathogens are pulmonary TB, measles, chickenpox, and pulmonary plague. And for short range, even SARS-CoV-2 and human influenza virus during aerosol generating procedures like intubating or collecting a nasopharyngeal swab. Then in such patients, what we need to do is we need to isolate them. So we should isolate them in individual room provided with adequate ventilation. So the room which the patient sleeps or admitted should have adequate ventilation with negative pressure facility. That is the recommendation, but then it is always possible. But adequate ventilation should be there, and the door towards the corridor should always be closed for this kind of patients. Only the windows towards the outside air, it can be open. Then PPE for healthcare workers, they should wear N95 respirators, okay, N95 mask, and the patient should wear surgical mask. And patient should be confined to the room all the time, okay, should not be moved here and there unnecessarily. And then the second transmission-based precaution is a droplet precaution. These, in comparison to the airborne, is a bit larger. They are more than 5 micrometers. So they are expelled by coughing, sneezing, talking, and come in contact with another person's mucosa directly or via contaminated hands. So example of this are pneumonia, meningitis, group A streptococcal disease, pertussis, diphtheria, influenza, and mumps. So these, because they are a bit bigger, they are heavier also, so they do not travel long distance. So special air handling and ventilation are not required for this kind of patient. Only for airborne, we need, negative pressure facility. Okay, so what are we supposed to do in case these kind of patients come to the hospital? So a minimum of 1 to 2 meters inter-bed distance is important. So the bed distance between two beds of patients should be at least 1 to 2 meters. Then cough etiquette must be taught to the patients, okay, with this kind of diseases. And PPE, a triple layer surgical mask within 1 to 2 meters of the patient, and N95 mask during aerosol generating procedures. So for this kind of patient, if we are intubating or collecting a nasopharyngeal swab, we need to use N95 mask. And transport, patients should wear a triple layer surgical mask during transport. And lastly, the contact precaution. So this is the contact precaution is how majority of the healthcare associated infections are spreading in the hospital in patients as well as again among the healthcare workers. So it can be either direct contact precaution or indirect contact precaution. Indirect, that means there's no intermediate object or person. For example, blood or body substance from infectious person coming in contact with mucous membrane or breaks in the skin of another person. So this is an example of post exposure. Remember, with needle stick injury or splashes of blood body fluid. So that is direct contact precaution. Then indirect, through intermediate object or person. So hands are the most important objects of indirect contact precautions, hands of the healthcare workers. So if we don't do hand hygiene properly, we end up transmitting infection from, in the hospital. Then second are the clothing of colonized or infected patient, patient care devices if shared among patients without proper cleaning and disinfection, and also environmental surfaces that are inadequately clean or disinfected. So example of in contact patient, we have the MRSA, CRE, VRE, MDRO. So these infections are actually multi-drug resistant organism. MRSA is methicillin resistant staph aureus, CRE is carbapenem resistant and enterobacterial, VRE is vancomycin resistant enterococci, and other multi-drug. So these are very dangerous organism. If there's an outbreak of this kind of organism in the hospital, then we end up in a very big problem on how to contain them and how to prevent them and how to treat them as well. So in case of patient with these kind of infections, with MRSA or MDRO, VRE and all, we need to isolate them. Okay. So individual room with a bathroom is recommended. And patient notes and bedside chart should be outside the room. And donning and doffing of PPE should be before entry and also after the exit. And the door should be kept closed at all time. And the door sign should also be placed. Then in case of similar infections, we can cohort patient. That is, we can put the same patient with same kind of infection in the same room, but a minimum of 3 feet bed distance, like 1 to 2 meters bed distance is important with curtains. Then PPE, in case of this kind of patient, the healthcare worker should be wearing gloves and gown, and hand hygiene should be done before and after contact with the patient and on leaving the room. Then, with regards to patient movement, actually the patient should be confined to the room at all times, and only for medically important situations. Then he can be transported, but the patient's colonized area must be covered. So, for example, you have a wound infection with MRSA, then we need to cover that wound area with a gauze or cotton or something, so that with patient clothing, so that the the organism does not transmit in the hospital. Then equipment should be, patient dedicated equipment should be used for single patient and must be disinfected before reuse in any other patient. And environmental disinfection. So with appropriate disinfectant, the room of the patient should be disinfected and clean. In case of infections where we do not know the route of transmission, then we follow the combination of all the three: contact, droplet, and airborne. So disease like Nipah virus and all, we do not know how they are transmitted. We're not sure yet, so we are you know following a combination of the three types of transmission-based precautions. Now we have talked about the basic of IPC. Now, with regards to the implementation, we need to actually monitor the IPC practices and also. So after training all our staff, telling them what to do, what not to do, PPE and all, we need to monitor them whether they're following the IPC practices or not. So we can do a hand hygiene audit. So like I told you, hand hygiene is the most important component of IPC. So that's why we can straight away go with hand hygiene audit and also biometric audit, and also we can do HAI surveillance. So these are the three things that we can do, major things to monitor the IPC practices in the hospital. So anything goes wrong in this, then we know that the IPC practices are not being followed properly. So hand hygiene audit. So the infection control nurse, like I told you before, has a very massive role to play when it comes to IPC practices, because she's the one responsible for auditing, for training, for everything. Okay, so she has to actually audit the hand hygiene practices in the hospital. So we have come up with certain checklists. So these are all actually downloaded from the CDC website. Okay, so we have made few changes from our side as well. So we will be sharing all of this. If we can make a WhatsApp group for all of us, we can share all these materials with all of you. Then you can customize them as per your needs in the hospital. So if you see here, hand hygiene audit, the first one is environment of care observation. Okay, so we are looking at alcohol-based sanitizer, whether they're being used in facility that contains at least 70% of alcohol. Okay, 60 to 95. So yes, no, and not used. Second one, the wipes that we're, alcohol wipes that we are using for injection, for collecting blood, are they being stored in a manner that prevents evaporation? Because sometimes in some hospitals we have observed that they put cotton just outside. They didn't store it in a proper container. And then third one is, how is the sanitizer dispensed, whether it is wall mounted, freestanding, or individual pocket size. So if we if the hospital is having individual pocket size, which of course is not possible, but it is not actually recommended because it will not be accessible to everyone, even to patient and all. But if it is wall mounted and freestanding, then it will be accessible for everyone, including the patient party, then all the personals in the hospital. Then the second part is the audit of alcohol-based hand sanitizer dispensers. Okay, so we have to look in all the rooms in the hospital, whether the alcohol-based sanitizer has is ready to dispense or not. That is, it is not empty, and if it does it dispense adequate volume or not? So that is also a very important uh, aspect of sanitizer. So, so a question is, what is adequate volume? So adequate volume is, there's no strict recommendation of whether it's 10 ml or 20 ml or 30 ml. There's no, quantitation actually. So adequate volume is a volume that covers all the surface of the hands and that requires a minimum of 20 seconds to rub before drying. So different people have different size of hands. So for a person with big hands, it requires, more of the volume of the alcohol. But for a person with small hands, it requires more volume of the. So it depends from person to person. Then the third one is audit of hand hygiene sink. So wherever we are washing our hands, we are auditing that as well. So whether the soap are available or not, towels are available or not. That's the sink drain. Okay, there's no evidence of backing up of water. Whether the sink is free from clutter or not. So all this yes and no. So the nurse will go around and look after all these things, and at the end of the month, she will come up with a gap analysis, and then try to rectify whatever there's gap with regards to hand hygiene practices. Okay, even for hand towels, because we are using cotton towels. So washing is very important of these towels. We do not recommend that wet towels to be used for wash for you know our hands. Okay, so whenever the towel is wet, it needs to be changed. Only dry towel should be kept. So in our institute, we are washing twice daily because we have two shifts for the lab technicians. So we are telling the housekeeping staff to wash the towels twice in a day. Okay, so the towels that are being used in a day, they are being cleaned and new towels are being replaced after every shift. Then the fourth one is the hand hygiene of adherence evolution, whether the healthcare workers are following the 6 steps and 5 movements or not. So the infection control nurse will go around and look at all the staff of the hospital, from doctors to nurses to housekeeping to everyone to lab techs, whether they're following the 6 steps and 5 movements of hand hygiene or not. So she notes down in this format, and then at the end of the month comes up with data that shows how many are following, how many are not following, how many are following partially, like that. So based on that data that you get every month, then actions can be taken. So in case there is a low for adherence to hand hygiene, then a training needs to be conducted for all the hospital staff, like that. And also for biomedical waste management audit. So as you can see here that there are, these are the steps for biomedical waste management: segregation, collection, transportation, treatment, temporary storage, final disposal, and this thing. So the nurse will go around and audit. So we have come across this material, this format on how to do biomedical waste management audit. So this is a daily audit sheet, and this is the monthly audit sheet. So in the daily audit sheet, there are 13 things that needs to be seen on a daily basis. So on top are the days. So 1, 2, 3, 4, 5, 6 till 31 are the days. Okay, so and then this one is the monthly audit. So these are mostly logistics and all. So for once a month, the infection control nurse can do the audit, but for daily audit, she must go around the hospital. So one format, one document for one section, for one part of the hospital, and she has to do this every day for the whole month. And at the end of the month, she needs to come up with a report, okay, based on this audit that she's been doing for uh, every day. Then after our audits and all are being done, then BMW audit and Hanagen audit are being done, then we can also proceed towards PPE audit, spill management audits, environmental cleaning distribution audits, and as well as sterilization audit. So for now, let us just the Hanagen audit and the biological waste management audit, because these are the major components of. Let me see if we are perfect in this, then we can move ahead with other types of auditing as well. So audit, the importance of audit is that we know where we stand. Okay, so at every month we know where we stand. So in a particular month we know that we are lacking somewhere there. Then we make corrective actions. Then I show you that if you follow this audit correctly and properly, I assure that our hospitals within 3 or 4 months we will be perfect in our practices with BMW management as well as IPC practices. So I urge all of us to actually undertake this audit um, uh, materials and do it in implement it in your hospital. Then let's come to the healthcare associated infections, HAIs. This infection is that these are the actually the infection that occurs after 2 days of hospitalization. There's 48 hours of hospitalization. And yes, these infections are not present or incubating at the time of admission. So, for example, a patient comes to the hospital for delivery. Please mute yourself. Please mute yourself. You're not even listening. Okay, so for example, a patient comes to the hospital for any other purpose, for example, for delivery, and she had no infection, no sign infection at the time of admission. But then, after she has come to hospital, taken delivery, inserted a catheter and all, then she started develop signs of infection. So these are called healthcare infection, where infection are not present beforehand, but it's due to the practice in the hospital that she gets the infection in the hospital. So actually, healthcare infection are the second most commonly, you know, encountered adverse events that happen to people in hospitalized in hospitalized patient in hospitals. So the first one usually is the adverse drug events, where you give some injection, some drug, they have reaction. But the second one is HIs, and the data is very compelling. It's very, it's huge. Okay, so nearly 1.7 million hospitalized patients annually acquire HAI while being treated for other health issues. So that's why patient safety has become a major issue in the present times because of all that. So the major type of HAI, which from the surveillance point of view, are these four. Okay, so the number one is central catheter-associated urinary tract infection. So you insert a catheter into the patient, and then she gets urinary tract infection. Second is the central line associated bloodstream infection, CLAP-C. The third is the ventilator-associated pneumonia, VAP, and the fourth one is surgical site infection, SSI. So out of these, the first three, that is the Gouty, CLAP-C, and VAP, are together called as device-associated infections. So again, we need to know how to do HI surveillance. So again, it is a very big role for the infection control officer or the member secretary of the committee, as well as for the infection control nurse. So for COTI, so these are the criteria actually. So 1, 2, 3, 4. All these four criteria must be met and must be met for a patient to be termed who gets a urinary catheter to be termed as a COTI patient. So all patients that gets a catheter, a Foley's catheter, needs to go into one register. Okay, so I'll just show you the register like this. Okay, so this is the COTI register for that you can keep in a hospital. So these are all the patients that gets a Foley's catheter. Okay, so we have the serial number, we have the patient ID, we have the date of admission. Okay, when was patient admitted, and the ward that the patient is admitted to, then the insertion date of the Foley's catheter, all this. Then sign and symptoms. S and S is sign and symptoms. Then date of onset of those sign and symptoms. Urine CS report, okay, whether urine CS was sent or not, and then what is the report, which organism, what is the count and all, and even sensitivity pattern of the antibiotics, okay, that have been tested for that particular bacteria. Then removal date of the Foley's catheter is here, and by subtracting removal date from the insertion date, you get the number of catheter days. For how many days the Foley's catheter was being placed in the patient. Okay, so all patient that gets a Foley's catheter needs to go in this register, and at the end, where's the pointer? And at the end of the month, you will have the total number of catheter days at the end of the month by by adding all the catheter days in that particular column. You will get the total number of catheter days for that particular month, and then you calculate the COTI rate at the end of the month like this. So if you see, I've highlighted in green. COTI rate is the number of COTI in the month. So number of COTI, that means the patients who have uh, met all the four criteria that have been mentioned here in the month into 1000 divided by number of catheter days that you get from the by addition of all those catheter days for all patients. So like this. So every month you can make a calculation for COTI. Then SSI, surgical site infection surveillance. We have three types of SSI: superficial, deep SSI, and organ or space SSI. So if you see here, I've highlighted in yellow. For superficial SSI, you need to follow up the patient for 30 days. Okay. Then for deep SSI, you need to follow up for 30 or 90 days, depending on the type of surgical procedure. And for third one, you need to again follow up for 30 or 90 days. So actually, this one needs proper follow-up of patients. So you can either do an active follow up, or you can also do a passive surveillance, that is passive follow up. So in case of active follow up, maybe you can tell the patient to come to the hospital like on at regular intervals, or you can actually just call them using mobile phone. Whenever the patient gets discharged, you tell them about the signs and symptoms of surgical site infection. Then on regular basis, maybe call the patient asking about these signs and symptoms of surgical site infection, then record whatever is being talked with the patient in our register. Or you can do passive, where you tell the patient to, whenever they see signs and symptoms of infection, to come to the hospital and to report to the hospital. So again, these are the criteria for all the three types of SSI. I will not go into details. You can all read. I will share the slides also with you like this. So at the end of the month, we need to calculate the SSI rate. So SSI rate equals to the number of SSI in the month into 100 divided by the total number of surgeries that are being conducted in that particular month. So there should be a register for SSI, where all patients who undergone surgery, minor and major, should go into that register, and follow-up has to be done. Okay, so whenever the patient comes to the hospital to report about the possible SSI, this format has to be actually filled up by the surgeon. Okay, so all this, everything is there, even the wound class, ASA score, all this, duration of operation, all this has to be filled up by the surgeon. And then this particular format, after being filled up, needs to be sent to the infection control committee, that is to the infection control officer or the infection control nurse to for verification and data. Then CLAPSI and VAP, I will not talk about them in details because not many of us are not using central line and ventilators. So these are just few criteria and all. So I will just share the slides with you later on. But then the most important thing that we can do at our level is prevention. Okay, so prevention of all these HAIs is of the utmost important for us. So we have certain kinds of preventive measures. These are called bundle of cares. So for all four types, we have the bundle of care. So for COTI, we have this bundle of care. So if you see here on the left, it's the insertion bundle of care, and on the right it is the maintenance of indwelling urinary catheters bundle of care. So these things, whenever you insert the catheter, then the nurse or the doctor who inserts the catheter needs to fill up this form and try to be honest as much as possible with with whatever practice has been done. Okay, so all this, I think I will not read each and every one. I think I'll just share all this with you. You will see that these are very very good tools actually to prevent COTI in hospital.
You have to record
Then for SSI, we have this bundle of care, like during the pre-operative period, what are the things needs to be done, peri-operative period, as well as post-operative period. Okay, then for again for CLAPSI and VAP also there are bundle of cares. So yes, and let's come to the last one of the IPC, that is environmental microbiological surveillance. So if you remember well, in the CAICAP in NQUAS and all, they used to ask about surveillance, swab surveillance of environment, of floor, of so people tends to do this on a routine basis. Okay, so they decide to do every month, every week, like that, every month or every quarterly. But actually, routine and random and undirected microbiological sampling of air, water, and environmental surfaces in healthcare facilities are not recommended. This is according to CDC and all other organization, that they do not recommend routine and random microbiological sampling of air, water, and surfaces. Okay, so the main indication for environmental microbiological surveillance are: number one, for dialysis water. So if you have dialysis facility in your facility, then you can send the water monthly for culture. And then for in case of any outbreak, and when you think that the environment is implicated, then you can send swabs from, for example, there's an SSI outbreak in the hospital. And then in that case it mandates that you send swabs, okay, from the OT table, from the anesthesia machine, from all the floors and walls of the operation theater for microbiological surveillance. And the third indication is research purposes. And number four, for monitoring environmental hazardous condition, like example, bioterrorism. And number five, to evaluate change in infection control practices. So in case, for example, if you have renovated your operation theater, then before you start any surgeries in the renovated OT, you need to do a swab, swab culture, or we call it microbiological sampling. Okay, so and then in case you change a disinfectant, for example, you have changed from hypochlorite to something else. So you want to know whether that disinfectant is working properly or not. Then in that case, also you can send microbiological sampling of the environmental surface. So I hope that is okay with everyone. And then lastly, I will talk about the laboratory, because we have seen in many hospitals the way that the samples are being transported from the wards to the laboratory is very it's not proper. It's very improper, and it is very risky, because they used to transport in in a, what is that called, thermocol uh, sheet which contains holes in it. They put vials in it and they move around the hospital. Or they sometimes use empty medicine boxes, injection boxes. They put samples in there and then move around the hospital for transportation of samples. So that is actually not a very good practice, because those things are very risky. In case of a fall, of accident and all, then there'll be spillage, there'll be, transmission of infection from that particular sample to people in the hospital. So recommended is that they use a box like this, a closed box like this. You can use a thermocol box or vaccine carrier. It should be closed, and there should be provision also for putting, ice pack and all for transportation of sample. So I would suggest that all the labs follow this. Okay, so whenever you transport sample the from the ward to the lab, you use a closed box like this. Then lastly, let's talk about documentation. These are very, very important when you talk about achieving your NQuas, achieving Kayakal and all. So we need certain documents with regards to IPC. So we need a letter that of the formation of the Infection Control Committee. And the second one is the minutes of the monthly ICC meeting. So this is the format, actually recommended format for recording the minutes of the meeting. So I will share the slides with you. You can have this. So there should be an agenda, decision points, time required for action initiation, and responsibility, who is responsible for certain job, okay, then remarks and all this. So all of this should be there in the minutes of the meeting. Then the third one is monthly HAI rates. Okay, so you can, after you doing a surveillance at the end of every month, you can record your HAI in this format. So different months and different high types, followed by the signature of the infection control officer, the infection control nurse. Then fourth one is actions taken in case of any HI outbreak. A record should be there. And then the fifth one is IPC BMW management audit reports. So out here we're doing this. So this is for hand hygiene. So we're doing like this. So we have kept all the things that we are assessing and different sections. Okay, so in the columns you see the sections in posterior institute, and in the rows you see the criteria or the thing that we are assessing. Or you can also do like this. You can report as per the healthcare type, healthcare worker type. So staff nurse, sanitary staff, doctor, ward attendant. How many in total number in that particular month you have assessed for hand hygiene? How many of them not followed? How many of them partially followed? How many of them fully followed? Then every month you will have a data like this, and based on this data, you can take actions on whether to undertake training and all. For you can actually take only a particular staff type to train in case the hand hygiene has decreased. Then okay, then training records. So there should be a register where you put all your training records, which contains the name of the hospital, the topic that you are training on, and then the name of the resource person that is taking the training, followed by the name of all the participants with their signatures, and also photographs if possible, because these days we are all having smartphones. And then staff immunization record, this is also very important. Then certain policies need to be developed, like the IPC policy, infection prevention control policy, hospital antibiotic policy, laboratory safety SOP, as well as the biomedical waste management SOP. So that is all from my end about infection prevention control practices. If there's any question, I would like to answer. Okay, no questions. Then I'll hand over the session to Dr. Larry Karsandi, who will be taking us through biomedical waste management. Go video on video. Yeah. Can you see the slide? Please respond if anyone.
Yes, sir.
Okay, let us start straightforward. As you can see here, the topic which I'm going to cover, it is the biomedical waste management, which is part of the standard precautions where Dr.
Robert has spoken just now. So we'll go ahead with the well, the overview of this training. First of all, we'll come to know about the reasons for concern. Why do we have to train? What is the importance of this training, particularly for this topic? Then secondly will be the introduction and classification of the healthcare ways or the hospital ways. Then following which we'll see about the categories of the BMW as per the recent rules. Then something about the requirements for BMW management at the healthcare facilities, right from the subcenter level above. Then 5 steps involved in biomedical waste management, and how to prepare hypochlorite solution from the concentrated solution as well as from the bleaching powder. And finally, we will show you about the documentation or the record keeping pertaining with this BMW management. So with the first slide, as you can see here, actually there are several reasons that needs the training. And the first one, as you can see here, which I mentioned, it is the health hazards. So if we don't if you don't manage the BMW properly as per the guidelines, there could be health hazards to the handlers, to the healthcare workers. It could be in the form of infections. It could be in the form of the sharp injuries or the nail stick injuries. And second concern here, I have mentioned it is the spread of infections. So there's high potentiality of the spread of infections, not only to us, and also to other living beings. And apart from that, it can also cause the pollution like the air, the water, and soil pollution. The last point here, as you can see, as per the WHO recent uh, report, the healthcare facility waste or the hospital waste usually comprise majorly of the general waste, which is non-infectious and non-hazardous. That is around 85%. And next is BMW, that is biomedical waste, which is infectious waste, that is around 10%. And the other one, it is other waste, including the e-waste, that is electronic waste. And then like for the used batteries, which is around 5%, which could be hazardous. So if we don't manage the waste properly in the hospital or the healthcare facility, all the 100%, or if we mix together all this, it will become hazardous as well as infectious. So always remember, I want to stress here that BMW is always considered as infectious waste. Not only yellow is infectious, not only red, all. It could be blue, it could be white also. All BMW is considered as infectious. Now, just to inform you, when we say healthcare waste or hospital waste, it comprises broadly of three: BMW, general waste, and other waste. So BMW is part of the healthcare waste or hospital waste. Then apart from that, we have the general waste. So for general waste, we usually have two. One is biodegradable, the other one is non-biodegradable. And other waste, I'll repeat again, it comprises of those e-waste, that is electronic waste, including the used batteries also. Just to remind or recollect to those of us who already knew also about the BMW definition, is the waste generated during the diagnosis, the treatment, or the immunization of human being or the animals or in research activities pertaining to or in the production or testing of biological materials. Now, in this single slide, you can see here hospital is divided into three. Like I said, BMW will be further divided into 4 categories. There is yellow, red, the white, and the blue. That you will come to know about them later on in details. Then we have the general waste. You have the wet waste, that is biodegradable, and dry waste, non-biodegradable, just at home only we are using. And then other waste, the e-waste, include the batteries. Please mute yourself. I couldn't feel. Now coming to the categories of BMW. As per the BMW rules 2016 with the latest amendment, the BMW, has been categorized into 4 categories: the yellow category, the red, the blue, and the white. There is no black. Okay. Always only these four: yellow, red, blue, and white. Now we'll see one by one. In yellow category, now you should know what to segregate. As you can see here, A, B, C, D, and if you read, it will take, the long time for this. So kindly see on this bolded letters, like number A here is human analytical waste, like human tissues, organs, to be segregated in the yellow. Apart from that, if you have animal analytical waste, also should be in yellow. Solid waste like the dressings, the plastic cards, the cotton swabs, contaminated with the blood or body fluids also in yellow. Then the expired and discarded medicines also in the yellow bin. So we have four, in only these bolded letters, if you see. Now EFGH, another four. We have chemical waste, suppose, for example, here like discarded disinfectants or the expired disinfectants like bleaching powder. Then F, even the chemical liquid waste, including the housekeeping, water that you have done for cleaning is also under the yellow. And then G, that is discarded linen mattresses and even the mask, the gown also here. And H, it is the laboratory waste, microbiology, bacteriology. And remember, blood bags also should be in the yellow. So basically, there are around 8 types of ways to be segregated in this particular color, yellow bin. Next, coming to red. First of all, for red, remember it is recyclable. So what to segregate here? First is plastic and then rubber items, including one, disposable utensils as tubings, bottles, intravenous tubes and sets, catheters, urine bags here, syringes without needles, and percutaneous with their needles cut and gloves. So till now, you could see that urine bag should be segregated in red, and then yellow blood bag should be segregated in yellow. Actually, these two are made up of the same material, that is plastic, only polyvinyl chloride. But the thing is that why blood bag should be segregated in yellow? The reason is that they consider the blood inside the bag, which is a human tissue. So you see A, human undergo waste. So that's why as per the guideline, they have written that blood bag should be segregated in yellow. Whereas for urine bag also, like I said, is made of plastic. So here we don't consider the urine, which is the excreted material, not the human tissue. That's why urine bags we consider the bag, which is plastic. So we segregate in red. Now coming to the blue, this one also is recyclable. And what to segregate here? The glassware. Please don't get confused here. Intact and even the broken glassware also should be segregated in the blue. And in certain hospitals in which there is an orthopedics department, so you may have some metallic body implants for disposal, that also goes to the blue. And remember, if there is, a glass vial in which there is, like, for example, antibiotic vial is a glass, but there is a, inside it, there's still the medicine still there or the drug, that goes to the yellow as expired drug, suppose you were to discard. But this one, if the empty one, it will go as a glassware to the blue.
Udah di satu kelas asli kelas kecap kayak ramnya kayak nasi poja radio berat poja dilarang poja.
All right. Then we'll go to the next one. This particular container should be leak proof, okay, and also should be puncture proof. And what to segregate here? All the metallic sharps, including the needles, the syringes with fixed needles, the needles from the needle tip cutter or hub cutter, the scalpels, the blades. All metallic sharps should be segregated in the white puncture proof container. So till now, you could see that out of these four color-coded bins or categories, only red and blue are recyclable. This you should remember. We'll see later on which one needs pre-treatment, which one doesn't need, and how to do the disposal. Before we go ahead, let us see some requirements required right from the sub-center above. See the waste it is required for all, like from the sub-center, PHC, CHC, up to district hospital. In the deep burial pit is required if in case you cannot access the common biomedical waste treatment facility. And sharp pits, I believe all of us we do have. And ETP, if it's best if you have for the liquid waste, and if not, you can do that Karataka model, which I will show later on. Apart from that, the best for pre-treatment, if you could get, it is autoclave. If you have autoclave, that means for pre-treatment is sorted out. You don't have to do chemical disinfection. So it is more effective also because this is sterilization, whereas if you do with chemical like bleaching powder or hydrochloride solution, even though it's 1%, it's simply just disinfection, not sterilization. So shredder also required, as you can see here, it is from PHC up to district level. Now, before we go ahead, let us see about the steps. The first one, or the initial step, it is the segregation. That means to segregate the waste at the point of generation. Suppose if you are working in the laboratory, so that is a point of generation, how to segregate the waste in those four categories. Next comes collection. Collection means the grade 4 or the support staff comes and collect those collected BMW, I mean segregated BMW from particular wards or like OPD or laboratory and transport within the premises or the hospital, that is in-house transportation, either to pretreatment or directly to central storage room. So we will see about the pretreatment also how to do, and finally about the storage till the waste will be collected and disposed. But before we go ahead, please focus on this particular slide. It's very, very important. Please note on this. The first point here, as you can see, any healthcare facility within 75 kilometers from the common biomedical waste treatment facility should not do on-site pretreatment, treatment, and final disposal. Instead, such healthcare facility should transport the BMW to the CWTF, that is common biomedical waste treatment facility, directly without pretreatment for final disposal, except, that is exceptional here, the yellow category H, that is laboratory waste or microbiology or biotechnology waste that needs pretreatment before transporting to the common medical waste treatment facility. So with regard to this first point, what it means here, like any hospital or healthcare facility which lies within 75 kilometers from the common medical waste treatment facility, no need to do pretreatment. They should send the waste directly to them, except the H, that is laboratory waste of yellow. Why it is so? You have to do pretreatment because this is considered as highly infectious among all. So no matter what, even if it is within 75 kilometers or so, you have to do pretreatment first before you send to common medical waste treatment facility. Please mute yourself.
খাবার দেখছে না
Okay. Anyway, let's continue. Now, if you don't do pretreatment, suppose for red waste within 75 kilometers, fine. But the thing is that if we do that, if the person or the support, for example, agency will come and collect that waste not within 48 hours, then in that case, you have to do the pretreatment. Meaning, if the second point, meaning like the BMW, you cannot store more than 48 hours. So if the person who comes and collect the waste comes after 48 hours, that means it contradicts the second point. It's written here that BMW cannot be left like that untreated beyond a period of 48 hours. I think Dr. Sabian has already mentioned, because if we keep the waste untreated after 48 hours, this can act as the source of healthcare associated infections. So we should not leave the BMW untreated beyond 48 hours. And thirdly, any BMW outsourcing to private agency for recycling, that BMW needs pretreatment before handing over to the authorized collector of that private agency. Here it means like if there is any particular, agency that comes and collect, as far as I know, the red and the blue has been authorized by the Meghalaya State Pollution Control Board to that Meghalaya Waste and Disposal Management Agency to collect. So if we give to them, we have to do the pretreatment. First of all, to ensure the safety of other people and also of the environment. So if you see here, taking all in like, almost like I can say always has to be pretreated. In fact, if they can collect within 48 hours and do the final disposal following pretreatment, then you can, it is acceptable. But if more than 48 hours, that means always has to be pre-treated before you give for final disposal. Well, the one I said just now, that authorization has been given by Meghalaya State Pollution Control Board. To this Meghalaya Disposal and Waste Management, as you can see here, for collecting, receiving, storing, transporting, packaging of BMW falling under red category and blue category. So these two will be given to the private agency. The name I have mentioned, as you can see here, Meghalaya Disposal and Waste Management. So as per this third point here, any BMW to be given to the private agency for recycling, that is red and blue, as per that letter, needs pretreatment before giving to them. Now let us see ahead about the pretreatment and disposal method of each category. The first one here, as you can see in yellow, here the first one, A, is human waste. Now we have collected in that particular yellow bin, in which there is plastic liner with yellow. Dispose that waste in the deep burial pit without any pretreatment. Then after that, the empty yellow bag should be discarded into a red bag, taking it as a plastic waste or plastic BMW, because it has been contaminated with the waste that you have kept inside that plastic bag. But yeah, now you can ask me, suppose here we don't do any pretreatment. Dispose directly into the deep burial pit. Remember, I'll show later on also that after you have the dispose or discard the waste in the deep burial pit, always you have to cover with a layer of lime of about 10 centimeter in thickness. That is, approximation only. So after each time we have discard the waste or the BMW in the deep burial pit, always cover a layer of lime over it. So that lime will disinfect that waste in that pit. Then the B, if we have animal and local waste, we don't have all of course. Then coming to the solid waste, like the cotton swabs contaminated with pus or body fluid. Similarly for this also, you dispose into the deep burial pit, then the empty yellow bag should be discarded into a red bag. Now, expired medicines and chemical waste. Suppose if you have with you the chemical reagents or the expired medicines, of course, there's no pretreatment written here, but how to dispose? I've written here, it will be handed over to MMDSL. To those who don't know, it is Meghalaya Medical Drugs and Service Limited. So how to do? Ideally the pharmacist needs to make a list of all these expired medicines and the expiry date of particular medicine and how much, like quantity. And that list will be attached with a letter addressing to the Assistant Drug Controller, the HSMI, following which ADC or Assistant Drug Controller will give order to the District Drug Inspector for verification. So the District Drug Inspector will come to your facility and verify these drugs or the drugs that you wish to dispose. And once it is verified, then MMDSL will come and collect for disposal. Please remember that. And now coming to chemical liquid waste. For chemical liquid waste, if you have, for chemical liquid waste, for this, if you have ETP, the best way is ETP. If you don't have, you can follow that Karnataka model. That will go to the soap pit, which I will show in picture. And then for discarded linen, mattresses, beddings, then mask and gown, first you have to shred and then dispose into the deep burial pit, then empty yellow bag to be discarded in the red bag. And the last one, that is edge of this yellow, that is laboratory waste. You have to do the pretreatment first. Don't discard directly into the deep burial pit. Like I said in the beginning, this is considered highly infectious among all those in the yellow category, where you have to do pretreatment and even other categories also. So that's why you have to do the pretreatment and the autoclaving is the best, if not possible, by chemical destruction using 1% hypochlorite solution. And you have to shred and dispose into the deep burial pit. Similarly for this also, empty yellow bag to be discarded into the red bag. So one thing I wish to tell regarding here, this particular yellow category, like most of the waste you can see here, we dispose in the deep burial pit. So there are times like you will get the gown which is of plastic, okay? So in that case, internally you are allowed to dispose or discard it into the red bin, okay? Because it's plastic, it will not decompose. Then similarly for blood bag also, after you have done the pretreatment, you can discard in the red bin. this plastic. Now coming to your red. The pre-treatment here it is autoclaving and shredding to prevent any unauthorized reusing, following which we hand over to that particular agency that I've shown. And for white, I believe all of us, we have sharp pit. You do autoclaving, chemical inspection, followed by shredding, and finally dispose into a sharp pit. Now for blue. For blue, similarly here also autoclaving, chemical inspection with 1% hypochlorite solution, contact time of 1 hour, then disposal. Intact glassware hand over to that person, that private agency, and broken glassware, if he takes, give to him. And if he doesn't, you can dispose it into a sharp pit. And if you have metallic implants, similarly, you have to do autoclaving chemical disinfection, either of this, and then you can dispose by handing over to the authorized agency. In this particular slide, you could see here is, a summary of what I have spoken just now. All those 5 steps. Segregation. The BMW should be segregated into those 4 column bins. Then collection should be collection of the segregated BMW. When the bins are 3/4 filled, why 3/4 filled? You cannot keep up to the brim of the plastic or the bins because to avoid any spillage. And within 48 hours, I have told you, within 48 hours, the reason is that if we keep this waste untreated more than 48 hours, this can act as a source of HI, because as one of the definition or the criteria of the definition of HI refers to the infection occurred after 48 hours of admission. Following which, the next step it is in-house transportation, meaning the transportation of the collected BMW, which has been segregated into 4 different categories, should be done in a covered trolley fitted with the wheels. Then after that, the last step, those that need pre-treatment will go for pre-treatment, following which will go for storage to be collected by all those agency or handlers. Then for pre-treatment, as you can see here, yellow category H I have mentioned microbiology, laboratory waste needs pre-treatment, the red, the blue, the white. But if they cannot collect the waste within 48 hours, even the rest of those yellow, you have to do pre-treatment. So after all, it will go to central storage room, where you will store in such a way different compartments, like yellow, particular, compartment will be there for the yellow waste, and also for the red and the blue. Whereas for the white, you can discard directly into the sharp bin. So let's see something about this deep burial pit, how it should be. The deep burial is allowed only on when there is no access to CBMWTF. So that means those which are accessible to the common biological waste treatment facility, but for us in Shillong, it is the Shillong Municipal Board. So for this particular yellow waste, we send to them. And after reaching there, of course, they will do the incineration or the burning of this waste at very high temperature. Whereas for those health centers which are not accessible at all to the common medical waste treatment facility, we are allowed to use the deep burial pit for disposal. A pit or trench should be dug about 2 meters deep. It should be half filled with waste, then covered with lime within 50 centimeters of the surface before filling the rest of the pit with soil. This is approximate the number actually for this 50 centimeters of the surface. You cannot just measure, it's impossible also. So on each occasion, that is what I mentioned beginning, when the waste are added to the pit, a layer of around 10 centimeters of soil lime should be added to cover the waste. Okay. It must be ensured that animals do not have any access to burial sites. Covers of galvanized iron or wire mesh may be used. Burial must be performed under the close indicated supervision. And this burial pit should be distant from habituation and located so as to be ensured that no contamination occurs to surface water or groundwater. The area should not be prone to flooding or erosion. The location of the deep burial site shall be authorized by the prescribed authority. So should apply or write a letter to the Meghalaya State Pollution Control Board for the approval of this deep burial pit. Then the groundwater table level should be minimum of 6 meters below the lower level of the deep burial pit. You see the picture. As you can see here, the bottom layer is a clay layer, following which we have kind of light gray to me here. So this is the BMW. Like I said, After each occasion, after you have discarded the BMW, you should cover with the soil or mix with lime. Then after that, when it's half filled, you should cover with lime first for 50 centimeter, the surface of the lime, and topmost should be the soil. Now coming to sharp pit. Sharp pit must be 1 meter, wide, even the length, the breadth, and the depth. Then should be lined with brick or masonry or concrete rings. The pit should be covered with a heavy concrete slab in which a galvanized steel pipe of about 1 meter height and suitable diameter is fixed to feed the shredded or mutilated sharps waste. And the top opening of the steel pipe shall have vision of locking after the treated waste sharps has been disposed in. Once the pit is filled, up to 3/4 capacity. This also you have to, approximate. You cannot measure 3/4. It can be encapsulation with binding material like cement. And once encapsulated mass is dry, sharp pit is sealed. And then another one you can rebuild if possible. If space, I mean, still there. This is just picture presentation, what I said just now about sharp pit. Now coming to the local disinfection for liquid waste. How to design this soak pit. A pit is dug into a ground and either lined with porous material or unlined, and filled with gravel and coarse rocks. A stratum of sand and fine gravel is spread across the lowermost to aid in the dispersion of flow. The pit is then covered on top. It's like this in picture. So that some debris and all will be retained by these gravels or rocks. Finally, like relatively the water after pretreatment by hypocrite solution will go to the soil. This is how it should be, this Karnataka model. Most of you already knew, I believe. Out here we have the big drum here, you can see in blue color. On top of it, we have 1% hypocrite solution container connecting through this pipeline, and another pipe connecting to the sink, and the lowermost pipe connecting to the outside that goes outside to the soak pit. So in your facility, if you don't have ETP, you can follow this Karnataka model for liquid waste management. How to do so? You can assign one sink in your hospital where you will do like this. Suppose now you have the liquid waste to be discarded. You have to pour into this particular sink, then you will go to this blue drum. Then particular amount of water, a hypocrite solution, approximately, you can release from particular container, that is 1% solution there, and allow contact time for at least 30 minutes. At the end of 30 minutes or more, you can release from below, okay? Then the mixture of, liquid waste along with that 1% of the solution will go to that soak pit, which I've shown this one, to this pipeline above. Now coming to autoclave, what are standards about autoclaving? The autoclave should be dedicated for the purpose of disinfecting treating BMW. So you may have autoclave in your facility for disinfection of the reusable items, but for treatment of this BMW, you should have a separate autoclave. You cannot use the same one. And when operating this, remember some parameters. The temperature should not less than 121 degrees Celsius and a pressure of 15 pounds per square inch. Also, a residence time of not less than 1 hour. If you remember, for disinfection of reusable items, it's around 30 minutes. But for this particular, disinfection of BMW, it should be minimum of 1 hour. This is because BMW, like I said, beginning considered as the infectious waste, as I've shown. Now coming to some details about the steps of each of those 5 steps. First of all is segregation. BMW should be segregated at the point of generation by the person who is generating the waste in the segregated color bin. That means the person who walks and generates the waste. Suppose in the laboratory, the lab technician has done some walk procedure. There could be some BMW generated like the needle, the cotton swab, and all those generated BMW by that person. The person herself or himself should segregate that waste in the particular bin. It doesn't mean after working there, then you will ask the grade 4 or somebody or your friends, your colleagues to do the segregation. So the person himself or herself should do the segregation, the ones who generate the waste. Then adequate number of color-coded bins, containers, and bags should be available at the point of generation for BMW. And always remember, BMW should never ever be mixed with general waste, I have said at the beginning, general waste is non-infectious, non-hazardous, whereas BMW is infectious. If we mix together whole thing of this waste, mixture will become infectious. And BMW bags and shops, containers shall be filled to no more than 3/4 full. Once this level is reached, they should be sealed and ready for collection. And some related posters for segregation to be pasted at the point of BMW generation, if possible. If you keep the bins, on the side of the room, just on the side, next to the wall, on that particular wall above the bins, you can paste the posters, for example, like this. So it can be of, reminders, like which ways in which color will go. Now coming to another step, that is collection. The time of collection, BMW should collect it daily, if not possible, every 48 hourly at a fixed time. I'll make an important point here, like I have shown you, should be collected when the bins are 3/4 filled or within 48 hours. So whichever is earlier. Okay, remember whichever is earlier. Suppose today is already 3/4 filled, you don't have to wait till tomorrow within 40 hours. You have to collect today itself. Okay, and suppose today is half filled the bin, and tomorrow also if you come is still half filled, it is almost reaching 48 hours, then you have to take it out and you have to collect. So whichever is earlier. General waste should not be collected in the same trolley in which BMW is collected. Plastic bags should never be stapled to avoid any sharp injury, but may be tied with a plastic tie. Replacement bags or containers should be available at each waste collection location so that full ones can be immediately be replaced. Now coming on that is in-house transportation of BMW. Now for in-house transportation, I think you understand, like in big hospital, district hospital, you will have not only the wards, you will have the lavatory, you will have the OPD, the emergency. So transportation, it means transportation of all those waste from various areas of the hospital to the treatment area or to the central storage room. So in-house transportation of BMW from site of waste generation or from their temporary storage to the pre-treatment area or central waste storeroom within the premises of hospital must be done in a closed transport trolley containers, preferably fitted with wheels for easy maneuverability. And patient trolleys, like I said, must not be used for BMW transportation. There should be a separate for that. And how to plan about the road and how it should be the road of transportation. Preferably, the road should have a low traffic flow of persons. Then the supplies and waste should be transported through separate roads. This central waste collection room should be easily accessible through this particular road and should be safe transportation of the waste or to be undertaken to avoid any spillage and scattering of the waste. This is taken from one of the health centers here in Meghalaya. They have a nice one trolley for transportation of the waste, in-house transportation, I should say. So they have particular color compartments within this particular trolley for in-house transportation. Gentlemen, I've already told you. Now storage. The central waste storeroom or central waste collection room for BMW should be situated within the healthcare facility premises. And it should be rodent and animal proof and also under the responsibility of a designated person and always under lock and key. And the storage time of waste should be as less as possible so that final treatment and disposal is done within 48 hours. Of course, to my right, this is should not be done. It's all mixed up, all colors here, and the right side. I mean, the right picture here. It should be like this: the central storage room, like yellow, particularly for yellow, red, particularly for red. Okay. Now coming to the other part, there is preparation of hypochlorite solution using commercially available concentrated solution. Usually, the supply is to come 5%, or sometimes 5 to 6% is the right. So 5 to 6, we take the average, it will be 5% on the, you will be considered as 5%. And now you are required to make 1% in 1 liter, that is 1000 ml. So how much water to mix with 5% to get that 1% of hyperconcentration of 1 liter? So if you see here from this table, if you wish to make 1% of 1000 ml or 1 liter, 1000 hyperconcentration solution from 5%, you should dilute this 5% of 200 ml with 800 ml of water. So you don't have to remember this by heart. Actually, there is a formula how to get this. This is the one. So you should remember this formula and how to do. So as you can see here, V1 is equal to C2 multiply V2 divide the whole thing by C1. Now let's see one by one. What is the V1? V1, it is unknown, so to say. It is a desired quantity of sodium hypochlorite solution. That 5%, how much you will take. As of now, you don't know. But V2, you already know. That is the total amount of solution desired. Okay. How much total? That is 1%. And then C1 is the concentration of sodium hypochlorite solution on the label. That is 5%. And C2, suppose it is the desired concentration of sodium hypochlorite. Suppose here it is 1% that you wish to make. So after putting all the values here, you could see V1 is 200 ml. Again, here what is V1 is the desired quantity of 5% commercially available hypochlorite solution. So how much water you will take? Now, like I said from the beginning, you already knew about the total volume of the 1% that you wish to make. It is 1000 ml. So you have to minus 1000 ml by 200 ml. So remaining 800 ml. It is the water that you should mix 200 ml of 5% to get the total volume of 1000 ml or 1 liter of 1% hypochlorite solution. Now, second one or second part, preparation of hypochlorite solution, not from the solution, but sometimes supplies comes through a powder, that is bleaching powder. So what you have to do here, you have to note on the packet or package how much percentage is mentioned on the label. So usually what I've seen, this is apply 30%. So if you wish to make 1% of hypochlorite solution of 1 liter, 1000 ml, how much gram of this bleaching powder you should take? So as per this table, it is 33 grams of bleaching powder should be mixed with 1 liter of water to get 1% hypochlorite solution of 1 liter. For this also, we have the formula Q equal to C1 by C2 multiplied by V. Here, Q also is known as a quantity of bleaching powder desired. How much you don't know, but you have to calculate as per this formula. So C1 is the desired concentration of the solution. So for example, this desired it is 1% hypochlorite solution that you wish to make. And then C2 is the concentration on the label. So for example, here in this particular slide is 20% mentioned in the label. So C2 is 20. And V is the desired quantity of solution. So if you wish to make of 1000 ml, that is 1 liter, that is V 1000. So after putting all those values, you will get that 50 grams of 20% bleaching powder should be mixed in 1000 ml of water to make 1000 ml 1% hypochlorite solution. But remember now, for example, you wish to make 1% hypochlorite solution of volume 1000 ml. So you have with you the water 1 liter. That means out of that 1 liter, take some of it in a mug or container, small container, where you will, you will pour all this powder. You have to make it a paste, right? Then after that, you dilute it properly, then you pour again in that particular remaining of 1 liter. Otherwise, if you take the extra water from the tap or from the other container, you will over dilute. So you will not come to 1%. I hope you are clear. While coming to the last part of the topic of this training, there are certain documents and records that you need to maintain with regard to BMW management. Here you could see around 20 documents. So let's see one by one. Form 1. This is accident reporting. This, you can download from the internet. Online is available. So accident reporting, what to report here? Let us see, next slide. Major accident. What it means by major accident here? It means accident occurring while handling of BMW having potential to affect large masses of public and includes toppling of the truck carrying BMW, accidental release of BMW in any water body, but excludes accidents like needle prick injuries and even mercury spills. Then for this particular injury or accident, where to report? This last point, information regarding all other accidents and remedial steps taken should be provided in the annual report fine. Whereas for industry injury and all, okay, should be done, or for other major accidents should be done in the Form 1. So Form 1 here, what I mean to say, it should be meant only for the major accidents, whereas the rest, like needle stick injury, spill, If there is mercury spill, should be mentioned in the annual report. So Form 2 is the application for authorization or renewal authorization. Form 3 is authorization from Meghalaya State Pollution Control Board. And Form 4 is annual report that you shall send, of the previous year within 30th June of this year. Suppose, for example, last year, 2024, you have to send the annual report right from 1st January last year to 31st December of last year within 30th June of this year to the Meghalaya State Pollution Control Board. Form 5, it is about the appeal. If you have any penalty imposed on you, then this is application for authorization of the burial pit. So you can write simply a letter like this, or just cap example of Mangar PSC. Then it's about the CTE. CTE, it is the consent to establish, and the CTO is consent to operate. These are required under the Water Prevention Control of Pollution Act 1974, similarly under the Air Prevention and Control of Pollution Act 1981. So for this, you have to do online. As far as I know, this I have got from the Meghalaya State Pollution Control Board, this particular link. Then it depends upon the total investment invested in that particular healthcare, the particular fees for it. As you can see on the right side, fee for consent for establish or to establish, and fee for consent to operate. Now, record of ETP with analysis report of the effluent. If you have the ETP, this, the effluent, the treated liquid waste should be sent for testing. That is done in Meghalaya State Pollution Control Board, and how often? 6 monthly. So for those who are using the Karnataka model, so the treated liquid waste using that Karnataka model also can be done for analysis or testing at Meghalaya State Pollution Control Board. Now there are two logbooks which I'll show now. The first one, this one, as you can see, of course, has to be filled daily, and it depends upon which ward, like or part of the or department of the hospital. Say, for example, from emergency or laboratory. So particularly, you have to fill here. Suppose for yellow, how much bags, okay, and you have to weigh also, and what pretreatment you have done. So this is in charge of that particular ward or the lab, responsible in charge should sign here. And the next one is similarly like this, is compilation for the whole hospital. Okay. So here, for example, see, you can see number of colored plastic bags and waste in kgs, that also for particular sections, labor room, how much, OPD, how much, laboratory, emergency, and so on. The treatment if you have done, and method of disposal finally. And if the waste like the red and blue collected by the private agency, he should sign here, and then signature of the infection control nurse. For the different report, which is one of the documents required to be maintained. First, the documents are three at the time. Three documents that you will bring and will be brought to you when they bring the new autoclave, of course. Installation qualification, operational qualification, and performance qualification. Please ask from the person who comes and install from the company. And not only that, you shall need also to show or to have the quality control of the autoclave to ensure that autoclaving that are doing or the sterilization for treatment of the waste, it is satisfactory. So this is the biological indicator. The whole thing is biological indicator, but chemical indicator is just this pink strip over this vial. So you should use this weekly if possible, but for this you shall need the incubator. So those not possible, you can use only the chemical indicator, whether it's kind of a tape where you can paste on the waste that you will do the sterilization. And for those available where incubators are available, then you can use the biological indicator, this particular vial. And training records, official letter should be there on education or the planned trainings. Of course, the topic should be mentioned, venue, timing, the name of trainees and trainers, attendance of training, and photos, and the training how often, yearly or at the time of induction of new healthcare workers. Apart from that, Dr. Robert also has said, has said already, health checkups of staff or as handlers yearly to be done, immunization records of Hep B and TT, BMW or other sheet, office order document of Hospital Infection Control Committee or BMW committee, the minutes or the meeting of HICC or BMW committee, then hard copy of the BMW Management Rules 2016 with latest amendment. And also you should have the agreement with the common biomedical waste treatment facility, that is Shillong Municipal Board within in the state of Meghalaya, or any authorized agency. Then the records of the autoclave operation, and also the chemical disinfection validation report. This one, it means if you are using the chemical disinfection using the 1% hypochlorite solution, so that particular solution that you have prepared needs to be validated. So you have to send for report testing for that. So finally, for this particular training, we have taken from two references. The first one is the guidelines for management of healthcare waste as per BMW Management Rules 2016, which has been formulated by two main bodies. The first one is Central Pollution Control Board under the Ministry of Environment, Forest and Climate Change. The other one is Directorate General of Health Services, which is under the Ministry of Health and Family Welfare. And the second one, it is the manual of the state, which has been approved by the government in 2022. So before I wind up, I just want to remind you, I have mentioned just now Central Pollution Control Board. It is this particular board that reinforces the, the proper BMW management in all healthcare facilities. And what else? So I think that's all from my end. If any question, please, you're most welcome. Silverin Maram, oh, you have asked question. I think, what about drainage bags for body fluid or other bags like surgical drainage? Are you there, Silverin Maram? Hello?
Yes, sir, I'm here.
Yes. Well, you were asking about the drainage bags, no?
Yes,
Hello?
sir.
Yeah. So it's made of plastic, I believe, right?
Yes, sir, like drainage bag sometime, surgical drainage, most of the time
Okay,
there will
okay,
be like blood. So like where will we throw those bags?
okay. First of all, if they are made, like I said, no, plastic or rubber, it should go to red. So see, some of us used to get confused that something contaminated with blood will be segregated in yellow. It is not as such. You have to think about the final disposal, okay? Because red waste will be recycled, whereas yellow you will discard. If you are accessible to common biomedical waste treatment facility, you will send to them, they will incinerate, they will burn. If you are not accessible, you will have to, discard in the for yellow waste, I mean in the burial pit. But in your case, if you are not accessible to, uh, you know, there's a common biomedical waste, like for example, yeah, the blood bag, which is made of plastic. In that case, you are allowed to keep in the red waste, considered as a plastic. Otherwise, it will not decompose if keep in the burial pit. Is it okay? You're clear?
Yes, sir.
Right. Then this one. I'll talk to that. The weight of the flight machine upon finding to high level. Well, from Motopra, anyone from Motopra? Are you there, Motopra PhD?
Oh, yes, sir.
Okay. You have asked here, sir, regarding expired medicines, do we release the tablets or liquids in the socket pit, or will send to CBMWTF? The weight of the expired medicines upon transportation is high, leading to high payment for the vehicles. May I know for the time so far, how did you do? How used to do about this? Hello,
So
Motopra?
like we
Yeah.
we uh, we just put in the yellow bag and we transport
Do?
with bucket box, sir.
Oh, dog, he takes for you. Actually, I said at the beginning regarding expired medicines. No, it goes to MMDSL. Okay. Hello. Yes.
Oh, okay,
How?
sir. Okay.
Yes. How to do that? Actually, you should write a letter to ADC, Assistant Drug Controller, DHSMI. Okay. Attach the
Okay.
list of those expired medicines. Mention how much number. So, say for example, the paracetamol strips expired on so date, and then you have to count the number of strips. Okay. Then
Okay, okay.
after the ADC receives the letter from your end, of course through your boss in charge only, he will
Yes,
give the
sir.
order to the district drug inspector. He or she will come to your place and verify those drugs, whether it is, as per what is given or not in the letter. Huh? And
Yes, sir.
once verified, they will be sealed. Then they will intimate when will be collected by the MMDSL. So that time you have to contact the MMDSL people that so and so this drug has been verified by the drug inspector. So which date you will come and collect? Then accordingly you come collect. Okay,
Okay, sir. Thank you so
you're
much.
clear, no? Clear, no?
Yes, sir. It's clear. Yeah.
Okay, okay, thank you. Any question, please? Any more? By the way, from all of you who attended this training, particularly for BMW topic, is there any health center which is accessible to common biomedical waste treatment facility? None. That means you will go to the deep burial pit. So I'll remind you again for the blood bag which is made of plastic. So obviously, if you discard in the deep burial pit, it will not decompose. So you can do that in the red bin. If you don't have anything more, so we'll start with post test. Please scan from this QR code and do the post test. You please carry on with the pretest. I think we will wind up the training. So thank you so much to all of you who attended this training. And please implement whatever you have learned the best. So thank you so much and have a pleasant evening ahead. Thank you.